Hello everybody, welcome to the Mayo Clinic. I'm Christopher Camp, and I'm one of the orthopedic surgery and sports medicine physicians here at the Mayo Clinic. Today, we're going to be discussing some of the intricacies of the elbow exam. I know for a lot of people, the elbow is somewhat of a black box. It can be a little bit difficult to determine different pathologies, both clinically and on physical exam. So today, our goal is to sort of help you sort through that. I have Sarah here with me today, so she's gonna help. She's gonna serve as our model, and we're gonna demonstrate a relatively complete and comprehensive general elbow examination. For me, anytime I'm approaching a patient who has an elbow-related issue, I try to keep things organized in my mind. There's really 5 different components to the exam. The first would be elbow range of motion. Next, we'll look at the elbow in 4 different anatomical sections. So first, we'll look at the anterior aspect of the elbow, then we'll move to the lateral side, then we'll do the posterior elbow, and finally, we'll finish up with the medial elbow. So I try to keep everything compartmentalized in my mind that way. That helps me when I'm taking the patient history and also when I'm organizing the exam in my mind. It's also how I sort through the imaging and ultimately come to the final diagnosis and treatment plan. So with that, we'll jump right into it. First thing I'm going to show you is elbow range of motion. Now this can be a little bit trickier for the elbow compared to other joints, and that's because the elbow flexes and extends, but also rotates, and the fact that it's attached to the shoulder, which is obviously a very freely mobile joint. So a few very minor, but I think important tips that I like to use. So first we're gonna look at her right arm. I like to bring the humerus up so that it's parallel with the floor. Next, we wanna supinate, which maximally externally rotates the shoulder. So that way the anterior surface of the humerus and the forearm are both facing the ceiling. It's helpful for me to have the humerus parallel to the floor because then that gives me a good frame of reference for the range of motion. And that way I know that any motion that I see is actually coming from a flexion extension rather than rotation. So for full extension, I'm going to support the arm, maximally extend to their level of comfort. Obviously here, a straight line is 0. And then we'll come up for maximal flexion. I kind of think of the coordinate system in my mind. So I know if I'm up here, that's a right angle, 90 degrees. If I go halfway, that's about 135. And we can see that she flexes beyond that. So almost to 145 or 150. So that's relatively straightforward how to measure flexion and extension. Next, which can be a little bit more difficult, pronation and supination. To do that, I measure both arms at the same time. So I stand in front of the patient. I'll have them tuck their elbows into their side. That prevents them using their shoulders to do any rotational motion of the forearm. So elbows are going to be locked in, and I demonstrate to them what I'm going to have them do. So first, do like this, perfect. And when I'm looking, so here she is in maximal supination, I'll take my hands and just give a little gentle pressure to see if there's any additional supination left. Also, it's very important to look at the distal radius and ulna rather than the hand, because you can have some rotation through the carpal bones of the wrist, which is obviously not coming from the elbow. So when I do this, I usually like to hold on to the distal radius and ulna to get a good feel for where that supination is. Pronation is the same thing. So we'll move in, again, filling the distal radius and ulna and taking it to the max or extreme. So that's how I measure elbow range of motion. Next, we'll move on to the medial elbow exam. So on the medial side of the elbow, the exam is really organized based on the anatomic structures on the medial side and the most common pathologies that we see. So if we think about what is on the medial elbow and what tends to go wrong, the most common things are the ulnar nerve, medial ulnar collateral ligament, obviously very common injury in throwers, and then finally the flexor pronator or medial epicondylopathy, or also called golfer's elbow. Those are the big 3 things that we'll see on the medial side, so that's what we'll focus our attention on. So when we take a look at the medial elbow, we'll start with the ulnar nerve. The first thing I'm going to do is take a look at the arm through an arc of extension and flexion. And here I can see the medial epicondyle is very obvious. The ulnar nerve obviously resides just behind it here. Very common to see ulnar nerve subluxation. Her ulnar nerve does not subluxate, but I can trap it right here with my thumb. So here it is between medial epicondyle, ulnar nerve, and then my thumb. I can trap it right there. So now you can see the ulnar nerve bulging out, and oftentimes, and then it snaps over as she goes into